And I will kind of do introductions every now and again as well for various people that come in on the meeting. So we're now at 82 people who are now attending. And I would just like to say a huge welcome to all of you. So my name is Anne-Maria Newham. I am the Executive Director of Nursing, AHPs and Quality. And this is the first meeting of this year, 2021. And it's as we mean to go on, really. So I normally do a couple of minutes where I just give a bit of context, a bit of horizon scanning, and just a bit of what's going on in the world. But before I do that, I just wanted to say that we've also got our lovely chair, Paul Devlin, who's also on the call, and we've also got some of our non-executive directors as well. I can see that Michelle's waving at Paul there because they do know each other very well, and so it's very nice for us to have our chair on the call, Paul Devlin, and also, like I said, some of our non-executive directors are also on the call as well. And we have 3 of our CQC inspectors, relationship managers on the call today who will be doing a short presentation. So what I was going to do is just a couple of minutes really of saying what's happening at the moment. So the CQC will describe to us the new methodology, what we can expect as an organisation. They're going to do their presentation for the first 20-25 minutes. We'll give them however long it takes. And then we'll split into 2 rooms. We'll take one room which will be for mental health, and the other room will be for general health. And in those 2 rooms afterwards, the breakout rooms, it will be to discuss what that means for us as an organisation, and it will be facilitated and chaired. So I just wanted to let you know that yesterday we had our what I would call an interview with the CQC yesterday afternoon. I think it went okay. I'm going to say to you all, I think it went okay. But what CQC want to then do is they want to delve a little bit further into some other areas within the organisation, namely CAMS, Rampton, Arnold Lodge, and adult mental health inpatients as well. Also, I just wanted to let you know, I'm not going to say anything more about that because I'm going to leave it for them to say everything else about inspections and new methodologies. The also thing I just wanted to say is that we've got a new communications lead starting soon in the organisation. She's actually going to be coming in for a few days this month and starting properly in February, and her name is Yolanda Martin. So just to look out for her. I have previously worked with Yolanda, so I just wanted to let you know that you're in for a treat, and she's really, really good at what she does. I also just wanted to mention as well that we have a lot of outbreaks at the moment within the organisation, COVID outbreaks. We're currently at 12 outbreaks. They're not subsiding. In fact, I've got another one that'll be a new one today as well, and that covers all 3 divisions. We have outbreaks at the moment. So I just wanted a bit of a plea really to say to people that it's either through passing of the mince pie plate on the Christmas Day, Boxing Day and the day after, or it's from the tin of baked beans at Tesco's. But either way, it's whether or not it's practices and behaviours that we have ourselves within the organisation, and also then practices and behaviours outside the organisation when you're in your own sort of like homes and shopping. So just to say, please be vigilant. Please adhere to PPE guidance, social distancing as much as you possibly can. It is absolutely virulent out there. It is spreading like wildfire. And some of these outbreaks, you know, within 2 or 3 days, I've got 15 staff and several patients being positive. So it's down to what we do, and it's down to our practices. So this is a huge plea, really, to protect your staff, protect your patients, and then your loved ones as well. One of the big things I wanted to say about that is that you can also support by having your flu vaccine. We're at 76% at the moment, which is absolutely fantastic. We're one of the best in the regions. But again, if you get flu and COVID, your outcomes are really, really poor. Okay, so this is something that you can do to protect both yourself and our patients. So please book in for your flu jab if you've not had it yet. It only needs 7 days in between, so you don't need to leave it 28 days as it was originally. So it's 7 days between the flu and the COVID vaccine. The other thing I just want to promote as well is that John Bruin chairs a session every Wednesday at 12 o'clock called Ask the Execs. And I just wanted to promote that session as well. It's a brilliant 45 minutes where you can ask somebody like the chief exec, the finance director, and any of the other execs any question that you want, anything. And believe you me, he's prepared to answer all sorts. You know, he's game for it, so make the most of it. We have quite a few people coming on it at the moment, but like I said, it's an opportunity that you would rarely get, and people seem to really like it, so please use it. The other thing is that we've had so far 2 question and answer sessions on PPE and COVID. And I just wanted to say that these seem to have gone down very well. We had more people on than I'd ever expected, between 80 and 100 people coming on those calls. And again, that's an opportunity for you to ask us any questions you want around PPE and COVID. And we will, if we don't know straight away, we'll go away and find a man who can. So these are areas that I think would be helpful to yourselves and be able to access information there and then. So with much further ado, I think we've now got 130 people on the call today. And I just wanted to say, I know I'd only told Michelle that there was going to be a few. So we did lie slightly, but it's okay because she's always game. And so we've got about over 130 odd people on the call today. So I'm going to hand over to both Michelle Edwards, Scott McMurray, and I know that Sarah is on the call, but I'm not sure if she's going to talk. I'm going to hand over to them to do their presentation and to say a huge thank you for doing this for us. This is really helpful for the organisation.
Well, Sarah is going to talk because she's going to be doing the presentation. So yeah, thank you for inviting us, Anne-Maria. I can't believe how many people you've actually got onto one call, and actually I can't believe I'm still connected because normally I get doofed off by now. I'll just introduce myself and then let Scott and Sarah introduce and let Sarah do the presentation. So I'm Michelle Edwards. I'm an inspector with the CQC. I've been there for 5 years after retiring from the NHS. And I'm the relationship owner for Rampton Hospital. So I'll hand over to Scott.
Great. Hi everyone. Yeah, my name's Scott McMurray, the relationship owner for Notts Health Combined Apart from Rampton. I've been the relationship owner for a year now, which has gone very quickly. But it's been a great year. I've learned a lot, and I really do look forward to this presentation. Thank you for having us. And to Sarah.
Hi everybody, my name's Sarah Dunkinson, and Anne-Maria, yes, you're going to have to listen to my dulcet tones because I don't know whether I volunteered myself or whether Michelle and Scott volunteered me, but I'll blame them for now. So I'm an inspection manager with CQC and I cover Lincolnshire, Leicestershire and Nottinghamshire. So the presentation that we're going to do today, I'm going to start with a bit of background information and work our way through it. Scott is going to keep pressing the presentation buttons for me. Michelle, can you look, if you've got any comments or any questions, put them in the comments box. Put your hand up. You know, please don't sit there in silence. Just throw them out there and we'll do our best to answer the questions for you. Is that all right for everybody?
Yeah.
Lovely. Scott, are you good to go?
Yes, I'll start sharing my screen. If you could just give me the thumbs up, Sarah, when you see it.
Bingo.
Lovely. So, how CQC regulates, expects and monitors care. So slide 2, please, Scott. So our purpose is to make sure health and social care services provide people with safe, effective and compassionate, high quality care. And we want to encourage and support services to improve. So our role is to monitor, inspect and regulate services to make sure they meet the fundamental standards of quality and safety. We do publish what we find, and we include performance rating to help people choose where they receive their care. As you have within your trust, we have our values as well. So excellence, being a high performing organisation, caring, treating everyone we meet with dignity and respect, integrity, sorry, I struggle saying that word, doing the right thing at the right time, and teamwork. So learning from each other to be the best that we can be. Next slide, please, Scott. So we monitor services, public or the private sector, and we are specifically a government regulator. So another example, which I'm sure you'll probably be more familiar with, is we're like what Ofsted are for schools. So we're sponsored, but we're independent of the government. So for CQC, our sponsor is the Department of Health. We work closely with that department to develop policy, allocate resources, and review and revise legislation. But we do make our own independent judgments about the quality of the health and of health and adult social services social care services. So one of the things that we worked really closely with the government recently was at the beginning of the pandemic. We supported adult social care providers to test their residents. That's just one example. So as a statutory body, so we're a statutory body, and this means that we exist only because we're established by an Act of Parliament. So we can only do things that are described in that Act. And our Act that we have to follow is the Health and Social Care Act. We cannot step outside these prescribed functions and powers. So, sorry, I've just lost myself. We are a public body, and this has many implications. So, for example, to be employed by the CQC is to hold public office. This means that we need to observe the codes and conducts of public employees. We must act fairly in accordance with public law, and we must also be transparent and accountable to the public who fund our work. We also exercise our powers on behalf of the public. We make sure that health and adult social care services are being delivered to an acceptable standard, and we have the power to ask those who provide and manage those services to change the way they operate. Next slide, please, Scott. So what does CQC regulate? So the simple answer is anything that provides health and adult social care services in England. So we only regulate in England. We have no powers to act in Scotland or Wales, but there are our counterparts that work in Scotland and Wales. So if there was a provider that worked across the border, say into Wales, we'd link up with our counterpart in Wales. So regulated activities, so they're what we regulate against. And these can be defined as specific things that are done by people who deliver health and adult social care. So, for example, one of the ones that springs to mind is the treatment and disorder. It's TDDI. Michelle, help me. Treatment.
Disease, disorder or injury.
Thank you. And so the list of regulated activity includes most of the activities that take place in hospital, care homes, GP surgeries or dental practices. Next slide, please, Scott. So we have 4 functions. So the first function is we register. So any provider that provides health and social care, they have to be registered with the CQC. The second function is monitor, inspect and rate. So we monitor and inspect our services to make sure that they're safe, effective, caring, responsive and well led. And then we publish a report of what we find and we include quality ratings. Our third function is to enforce. So we use our legal powers to take action where we identify poor care. And our fourth one is the independent voice. So we speak independently, publishing regional and national views of the majority of quality issues in the health and social care, and encouraging improvement and highlighting good practice. So examples of this are the state of care report, and also thematic reviews. One of the last ones was learning from deaths. Next slide, please, Scott. So we have 5 directorates that help us meet our responsibilities and fulfil our purpose and role. So we have 3 inspection directorates, so adult social care, hospitals, primary medical services and integrated care. Then we have the strategy and intelligence directorate, and then we have the customer and corporate services directorate. Next slide, please, Scott. So our key questions. So our key questions when we come to monitor and inspect services are in 5 domains. So safe. Are people protected from abuse and avoidable harm? Effective. People's care and treatment supports and achieves good outcomes, promotes quality of life and is based on the best available evidence. Caring. Staff involve and treat people with compassion, kindness, dignity and respect. Responsive. Services are organised so they meet the needs of the people. Well led. The leadership, management and governance of the organisation assure the delivery of high quality care, supports learning and innovation and promotes an open and honest, fair culture. Next slide, please, Scott. So I hope you can see this slide because the writing is a bit small. So what we do is we put the pieces of the jigsaw together in order to support the inspection. So we receive lots of information about the provider from other people than the trust and yourselves. So carers contact us, patients contact us, some complaints come into us. We only deal with Mental Health Act complaints, information from the provider and information from stakeholders. So that could be from Healthwatch or from NHSEI or from government. Pre-inspection and information gathering. So we have our CQC record, so we get lots of inquiries sent to us every day about safeguardings, about deaths, about complaints, about positive experiences that of people that have had, and they all come into Michelle and Scott and they review all that information and we hold it locally. We also we have regular engagement meetings with the trust where we share information. They keep us updated of all their new the new ways of working or new policies that are coming in. The intelligent monitoring, so patient surveys, clinical quality and activity, so the outcome of clinical audits, and contextual information as well. So about the population that live in Nottingham, about the public health data that's held by Public Health England. And then we do the on-site inspection. So we observe and we observe, we talk to people, and we link this all together to form that whole jigsaw, and that's what we report on. Next slide, please, Scott. Oh, excuse me, I've got a funny throat now. So the types of inspections that we do. So ones that you're probably really familiar with are comprehensive inspections. So these inspections are part of our monitoring and they used to be done every year. And we tell the trust when we're carrying out the well-led review, but we don't tell the trust or yourselves when we're coming out to do a core service inspection. Then we do focused inspections. So focused inspections aren't announced, and we carry out this type of inspection to focus on an area of concern or to focus on an area of improvement. So one of the examples that I can give as this is we came out to Lucy Wade ward because of concerns, and then we didn't actually do a follow-up inspection when we know there had been improvements, because by that point COVID had hit and we were in lockdown, but we would have gone back in normal circumstances to look at the improvement in action. So obviously this has changed somewhat because of COVID. So we're very conscious that, as we heard from Anne-Maria at the beginning of this session, that COVID is rife and, you know, it's life-threatening, and we do not want to put more burden on you and your teams by coming out and doing an inspection. So initially, when COVID first hit, our inspections stopped. The only way that we would come out is to look at risk. Any risk issues that we felt that we had to come out, we would come out to. What we've done is we've developed a transitional regulatory approach, and that's what Anne-Maria was saying about the interview that we did yesterday. So next slide, please, Scott. So the interview, for want of a better word, that we had yesterday focuses on safety and how effectively a service is led and how easily people can access that service. So Sharon did a great job at sending us loads of information. We already had a lot of information because of the engagement that we've done with the trust. And what this approach allows us to do is strengthen the monitoring, and it's based on specific existing key lines of inquiry. So they're the questions under safe, effective, caring, etc., etc. And that we're using technology and local relationships to have better direct contact with people who are using services, their families and staff. And then, like I said, we're just using targeted inspection activity where we have concerns. So this was not an inspection, and we do not rate services after this call, but it allows the CQC to have an understanding of the risks that each of our provider is facing currently and whether or not we need to take action. Next slide, please, Scott. So for those of you who haven't been involved in an inspection, I just want to sort of say what happens. So hopefully now you've seen our beautiful faces and you'll recognise us if you see us walking around your services. And we'll want to talk with you, with patients and with carers. We'll look at the environment of which you work in and the patients are cared for. We'll review patient records, including physical health records as well. We'll check your clinic rooms and your medications. We'll review policies and procedures. We look at minutes of meetings and incidents. We check that the interventions that are used to support patients are in line with national guidance. And we will observe. So patient and staff interactions, ward round CPAs, professional meetings, patient sessions. So I haven't put the key lines of inquiry in full in this presentation because there is quite a few of them. What I've done is I've put a link in here, and this will be sent out. I've seen some of the questions that are coming. This will be sent out and shared with everybody, so don't worry. And you'll have the link so you can have a bit of light reading to go through all of the Chloes. Next slide, please, Scott. So how can you and your team support an inspection? The first thing is, please don't panic. You know, me, Scott and Michelle, we've all been where you are, and we've had inspections when we were in clinical practice. We are not there to trip you up or to trick you at all. We come out to inspect and we want to get a better understanding of the work that you do. So tell us. If we ask you something that you don't understand, come back at us, question us. I remember that I went into a service and I asked about audits, and I knew that they did them because I'd seen them. But when I asked staff, they didn't have a clue what I was telling them about. When I rephrased the question, they knew exactly what I was talking about. So, please do ask us to explain to make sure you fully understand what we're asking of you. And make sure that you tell us or show us the good things that are going on. Celebrate your success. Now, Sharon's really good at sending us some compliments that you've had, awards that you've won, or brilliant pieces of work that all of the core services has done, and that's great. But when we get out on inspection, it seems that nobody wants to talk to us and everybody runs away because we're really scary and we don't get told about the good things. And you know, it's your time to celebrate with us. You know, one of an example that I can give of that is I went into a trust. It wasn't your trust, and we did the inspection, and there was work to be done. But when I went back and had an engagement meeting, a nursing assistant came into the engagement meeting and was really quite cross. And I was like, oh, well, you know, what's the matter? Well, you never mentioned anything. Nobody asked to see the room, the snoozeland room and sensory room I've set up. I was like, oh, goodness. So off I went to see. This nursing assistant was amazing. She had, on her own, asked for permission to convert a bedroom that was no longer fit for purpose into a sensory / snoozeland room. She had gone out and got her own funding for all the equipment in the room, and then worked with estates and facilities to get it all set up. And it was really low-level sensory work that you didn't need to be trained to do, so any member of staff could use it to support patients when they were struggling, and it was brilliant. I mean, they had a whole open day and everything, and nobody told us on the inspection, so we couldn't write about it. And partly, you know, that was a hands-up moment. We should have asked more questions, and you know, but what a shame that all of that good work has been missed. So please do tell us, and please do show us.
I think it's also worth mentioning, Sarah, that it is anxiety provoking when we pitch up, and you're not going to remember everything. And I very often say, look, I'll go off, do a bit, and then have a think about things, write things down, and then I'll come back in a couple of hours, and by that they've had a chance to think about those positive things.
Yeah, absolutely. So support patients to get involved as well. You know, ask them to. We have to look at the environment. That's inside as well as outside of the ward and in their bedroom. So ask them to show us around. You know, support them to be actively engaged in the process. You know, a lot of patients do want to be involved, and they are very vocal, which is brilliant. We like people that talk to us. It's great. So, and point inspectors in the right direction as well. So sometimes, you know, I suppose my plea is we go out to lots of different services, lots of different providers, all of which do things in slightly different ways. Excuse me, I'm going to cough. So, for example, the patient record electronic system might be slightly different, or your ligature audit might look slightly different. So support us to get the information that we need. We're not trying to, you know, trick you, but, you know, point us in the right direction. Tell us where to go and look. You know, it's really helpful. And please remember, as much as it is nerve-wracking, it is, you know, scary that you know, you don't know what the outcome of the inspection is going to be. But please remember that when we come out to services, we always come out at the point of good. So we don't come out looking for poor care. We come out looking for good care. It's just unfortunately that sometimes we find areas of concern, and we have to report on this. And this isn't to get people into trouble or, you know, to upset people. It's so that we can support services to improve. And one of the things that I didn't fully understand when I was a clinician prior to coming into regulation, that we have the same goals. You know, you do the work that you do because you want to do the best for your patients and you want them to get to where they want to be. And that's exactly the same reason why we do it. We want the best outcome for patients as well. So the only difference is we follow different paths to achieve them. So it's really important. So please see us as part of your team. Ask us questions. You know, talk to us. There's links on the last page. Tell us what you're getting up to, because the more we work, the better that we work together, the better the outcomes will be. So that's my plea. Next slide, please, Scott. So once we've done our inspection and you've been fabulous and helped us getting all the information that we need, we make a judgment. So we have 4 ratings. So inadequate, requires improvement, good and outstanding. And there's the characteristics of each of the ratings for you on that slide. And in order to make that judgment, we don't make that judgment in isolation. So initially, it will be the inspector and the inspection manager that makes the decision, but then it goes through quality assurance processes. So it goes all the way up to our deputy chief inspector. We make sure that we're sticking to these characteristics. We make sure that we've got robust evidence to say, yes, this trust is good, or yes, this trust requires improvement. I mean, so it's not just one person who makes that decision. And I think that's why I feel that sometimes it feels like it takes forever for the reports to come out to trusts, and it's because of that quality assurance process, because we need to get that right, because the implications is if we don't get it right, you'll end up with the wrong ratings. Thank you, Scott. Can we go on to the next? Can we go on to the next slide, please? So this is just basically a synopsis of what I've said to you already. So we look at the key lines of inquiry, we gather and record evidence from a variety of sources, and then we carry out the inspection, we make judgments, and we build the ratings in, and then we write a report and publish alongside, publish the ratings alongside it. So this is where you can, so we've got a website, and on the website there's a plethora of information for you to read. We are very active on Twitter. I'm not very good at Twitter, I have to admit, but we are very active on that. Also got Facebook, and in the email I've put in there about the contact us form. So it's a link, it's an online form. You can do it anonymously, or you can put your name down, and you can tell us about the good work that you've been doing, or you can raise concerns if you feel that there are concerns that needs to be raised as well. And that's it from me. So are there any questions, Michelle and Scott, that came up that we need to go back to?
No, nothing as yet, but maybe give people a couple of minutes to digest.
Can everybody put their mics on mute, just because Michelle's got reverberations or whatever you call it. Reverberations. That's totally the wrong word. It's a Friday afternoon word, that is. Carolyn White's got a hand up, please.
Thanks. Thanks for your presentation, Michelle. It's a helpful kind of refresh and update. I'm one of the non-execs at Notts Healthcare. I'm just interested really in, we're obviously being asked to take a more light-handed approach in terms of governance, given the enormous pressure that the NHS is under at the moment. And I just wonder how the CQC has interpreted that guidance as well, and how your approach might have been ameliorated, if that's the right word, when you're coming in to review services.
Oh, excuse me. We are very aware that, yes, we need to lessen the burden. And I think we have done that to an extent. I think there's still a way that we can improve on that. And one of the things that we're going through a process of change because of COVID, like so many different providers are, because we've found so many different ways of working that have benefited us because of COVID, that have lessened the burden on trusts. And one of the things that came out, and especially with this trust, we had lots of work to do with ICETRs, so independent care, education and treatment reviews, and both CQC and NHSEI were asking for the same information. So we took learning from that, and as part of our development in transforming the way that we do, it's about matching up the burden on trusts for different stakeholders, what information that they need. So yeah, I think that will support us. But I think in the meantime, I think the engagement has increased, and I think that's been really valuable. But the amount of information that we've requested, I believe, and Scott and Michelle might be better, has reduced, because we're aware that you need to be doing what you need to be doing for Nottinghamshire, rather than pandering to our needs and our wants.
Yeah, I'd echo that. I think it's important as well. That strategy is out for consultation as we speak. So please feel free to read it and comment if you feel there's something that we need to know about.
Okay, thank you. And can I just ask another question as well? And this is probably a bit like how long's a piece of string, but obviously we're an organisation that's currently rated as requires improvement overall, and we know that we're not going to have that rating reviewed anytime soon. And by doing little bits of the service, we'll incrementally, hopefully, evidence to you that we're providing really good quality care. But there is an anxiety around being able to have that overall inspection and get our rating to a place where we believe we're currently performing. So it's probably an unfair question given the circumstances, but I just wonder what your thoughts are about how long it's going to take you, because I'm guessing there's lots of people asking a similar question.
Yeah, it comes up every time in our engagement meetings or in just general conversations that we have with Anne-Maria and Dr. Bruin. So I know it's very high on their agenda, and it's really unfortunate actually, because it was planned for us to come in June
Last year.
So that was obviously kiboshed by COVID. One of the things that, and we feel very much, I mean, we've only worked with the trust, as Scott said, since last January, and we are in agreement that the work that the trust has done and the improvements they've made are great, and it very much feels that the ratings don't match the work that we know that's going on. So we're just as keen to come in as you, and I have asked and been told no, but it must have been about a month ago now, because as a group of inspection managers, we've been saying it within our governance meetings, it's not fair that we're just going out to look at risk, because actually one of our core approaches is that we report on good care as well. So it's not fair that we just go out looking at risk. We're only doing half of our job. So there was a list, and I've told Anne-Maria and Dr. Bruin this, there is a list of trusts that need to be re-inspected because of the improvement that they've made, and Notts Healthcare is on that list. The meeting that we had yesterday, where we looked at the Chloes with regards to well led, I think once we've got that all written up our end, that will really support us coming out as soon as we possibly can to do that re-rate, because if you look at the last report and then you look at what we went through yesterday, they're poles apart.
Yeah.
So it is very much on our agenda. I do bang the drum. I am very much, I've worked with Anne-Maria and Dr. Bruin before, and they know, I'll call a spade, and if action needs to be taken, it needs to be taken. But also, if we can do something that supports you and gets you where you need to be, we will do that. So I can't answer fully, but what I can say is that the new way of working for us comes into force in May, so we're currently in the consultation process. Whether that means we can come out in May or we can come out sooner, which would be my preference, I don't know, but it's where this list is sort of sitting. I don't fully understand whether that list is sitting for us to do during the consultation process or once that process is finished. Did that answer your question?
Yeah, kind of. Yeah.
Sorry.
No, it's fine because we're all living in challenging times, aren't we? And I kind of guessed, I knew there wouldn't be a definitive answer, but that's helpful that you're kind of pushing at the door. Thank you.
Okay, I can't see any more questions in the side. We just had one was a clue, but we've answered that. Key line of inquiry. Oh, bless her. And Manjit is one of our new non-executive directors, so it's nice for Manjit also to be on the call today. And she's just basically said the delay in re-rating is also unfair on staff who worked so hard to make those improvements, and we know that. And I would like to just say to everybody on the call today is that we've worked really hard with Sarah and Michelle and Scott, and they are working really hard on our behalf as well. And I think the slide that she put up and that comment on the bottom in bold, I thought was really interesting, that we both want the same thing. So we as a trust want the same thing as the CQC wants, but we just have to come at it from a slightly different angle. So they're not working against us, they're working with us. And I think that's a really important relationship for us to have. I just was see if there's anything else on the side on the information collected. PI, where are you with the collection from the central sources, not from the trust directly? So Richard is asking about where you're at with collecting from other sources, not just from when you ask us directly. Where are you at from other sources?
Yeah, well, I suppose Anne-Maria, it's the PIR is a large exercise to do as a trust. So, especially from my angle, the ESR angle, a lot of information sits within data warehouses within ESR, and to get that level of information you require does take a lot of time. And actually, if you're asking that from different providers time after time, the time, I won't say wasted because it's not wasted, but the time that takes, and that takes out of a day job, is massive when a proportion of that data you may be able to get centrally from ESR directly. So the challenge is that something you're looking at to say provider time? And if so, where are you with that?
Yes, we are, but I couldn't tell you because that's not something that we're involved in as the ops inspectorate. But can I take that away for you, Richard, and come back?
That'd be really helpful, thank you very much. And if you want more information on that, Sarah, what it means, where I think we can get the information from, quite happy to have that conversation outside this agenda. Because if you want to come back with directly, I'm quite happy to say I think you could get X from here, and work with you on that. I'm more happy doing that.
That's brilliant. Yeah.
Thank you for that, Richard.
Take it away and come back.
Brilliant. I've also got John Bruin who's got his hand up. You'll love this one, Sarah. Wait for it.
No. He's not going to ask me to tell a joke, is he?
No. Go for it, John.
Oh, thanks very much. Get a word in. Thank you to CQC colleagues for that presentation. I thought it was really useful, and I'm really pleased that so many of our staff have been able to hear that from the horse's mouth, as it were, because one of the things, Sarah and team, that you've done, you've been really open and transparent about your motivations, why you do it. And there was one of those slides in there that was that Paul mentioned. It's really salient. We're here for the same reason. We just come at it from different paths. And I myself have fallen foul of this. A long time ago now. I was arrogant enough to think that I knew what I was talking about and what did the CQC know. But that's a long time ago now, and I've learned a lot working together. And I think we've got into a good position. And we appreciate your challenge about the restrictions of coming in, as Manjit has put in the chat. That's testament to our staff, that many of which are on the call, that have been fundamental in starting to do this really important work. So our thanks are out to them as well. And I'm confident at some point in the future we'll really be able to showcase the fantastic stuff that we're doing and get those ratings where they need to be. Just one point that might just be worth double checking. I don't know, Anne-Maria, whether you did any of this beforehand, but in terms of what the CQC identifies as core services might not fit with what we regard as core. So there'll be some big services with high volumes of people going through that aren't on the inspection list. For example, things like IAPT, and often some of the specialist services too. So things like eating disorders and perinatal. But my understanding is that we're still able to give you information about some of the great stuff that we're doing that you just won't formally inspect and rate.
Sarah, did you want to come back on that one?
Yeah, that's a really good point, John. Thank you. So what I will do prior to sending over the slideshow, what I will do is I will put a slide together for the core services and what we call our specialist services. And I get it all the time, that we're a specialist service and you never come to see us. And it's like, and take that as a good thing, because that means you're doing what you need to be doing and there's no risk, but it's really frustrating. But that doesn't mean we don't want to hear from you. Absolutely, keep it coming into us. And it's also, so for example, if you're doing some dual work with sort of eating disorders, and like, you know, community mental health, for example, we can pick it up that way and flag it that way, but they don't get their own report. And the other thing, just picking up on what Manjit said, it is unfair on the staff, but one of the things that we have tried to do, we were in Rampton just prior to COVID, the first lockdown, and we have gone out to some of the mental health acute wards, and their reports that they got that we wrote after that, I hope highlighted the work that the staff have been doing and that we've noticed the improvement that they've made. And I would just like to say as well, you know, the staff that we've met and that we've had engagement with, they have been fantastic. And some of the stories that I've heard from staff when I've been out, absolutely fantastic, you know, can't fault them and just thank them. We know that they're doing a brilliant job. We can't wait to get back out there, but we need to do it as safe as possible to get the best result for everybody, really. So yeah, I fully understand, and it's just as frustrating for us, but please keep doing what you're doing. It's not going unnoticed, and we will shout it from the rooftops at every opportunity.
That's brilliant, thank you. Carolyn, you've still got your hand up. Is that a new hand?
Yeah, it's a new hand, if I might. It was just a comment really about the PIR, Sarah, and the data collection. So in my previous life as a director of nursing, I know the enormous burden that this places on trusts in terms of data collection and submission. And I'm also an executive reviewer for CQC, so I've seen it from the other side as well. And I know some of that information is absolutely vital to your pre-inspection kind of assessment, but I am yet to see all of the data that's collected being used and shared. So I think one of the things that this kind of COVID situation has taught us as an organisation is that we can work in different ways. We can work with less information. We don't all have to be in a room together. There's all sorts of things that have come out of it as positive. And my challenge back to you and your colleagues is please go away and ask yourselves, do you really need all of that data? Because it is so hugely burdensome on operational staff who are, you know, in normal circumstances working really, really hard. At the moment, we're asking above and beyond what we should be of them.
Absolutely, so. Yeah, and like I said, that is, you know, if you please, you know, use the consultation process to voice that as well, because we do say that, and it's quite. I suppose the information comes in, and I don't think I've ever done an inspection where I haven't then had to spend half a morning with a trust explaining actually what we're asking for, because it comes from our analysts. So actually what the analysts want is something different to what ops want, so we have to then decipher what the trust needs to give us, and so I fully understand where you're coming from, but I will look into it. I will come back and have them conversations. But if you want to be involved in the consultation, and data is a big one, please put that, go online, click the button and put your thoughts down, because it would be really useful, because it's hard for us on the other end to go through it, believe it or not.
It is, and as soon as we receive it, it's out of date.
Yeah.
So we go on inspection, revisiting the data, which has invariably changed. So we share your frustration, and we have voiced that.
Okay, thank you so much. So I can't see any more questions and no more hands up. So just a massive thank you to our CQC colleagues. I think it's been really helpful. I think you've laid it out really clearly. I think it helps the organisation to understand what the future looks like for us. And I certainly think that working together for the next 6 months, 12 months is something for us to look forward to. And I particularly think that staff now understand it's about celebrating, showing you the good, because we've got some great things to show you. So I'm going to close this session down now and say thank you. For all of you on the call that are going to stay and go into your chat rooms, there's a breakout room 1. You can find it in your diary, so just click on the link. But I want you to all come back to this link at 3:10 for us to just have a conflab really about what we've heard and also what we think we can do going forward. But just again, thank you very much to CQC.
Thank you. Enjoy
you
the
for
rest
having
of your afternoon.
Thank you.
Bye.
Thanks, guys.
Bye.
Stay safe. Bye.
Bye.
Hello everyone. So my name's Anne-Marie Newham. I'm the Executive Director of Nursing AHPs and Quality. I can see that we've got about 50 odd people on the call now. I want to increase in quickly. Half a second because it's just going a bit. Obviously mental health have just finished their session because everybody's jumping in now. Okay, let me just. I wasn't expecting so many people to come back in, actually. We're at 76 now. Okay, so my name's Anne-Marie Newham. I'm the Executive Director of Nursing AHPs and Quality. Just wanted to say a big thank you to everybody for their contributions. I think we had a really helpful conversation in our general health part of it. So that element of the afternoon was really for you to have an opportunity to just have a chat about, what did you feel about the presentation? How did you feel that could affect you? What are the implications? What do we need to take on board? Is there anything we need to go back with? Is there anything we need to push back on? Challenges, etc. So certainly from my perspective, in general health, one of the things is that, of course, they've not been inspected since 2014, a lot of those services. And so some of the attendees felt that they would have liked a little bit more detail about what to expect from a inspection around community health. They felt it was maybe a little bit too general, and they would have liked a little bit more specific. So we can certainly go back to the CQC inspectors to say that some of our services have not been inspected for such a long time. What could they expect to see, and what kind of questions? The other thing that in my session, which I thought was really interesting, is that there is still a perception that people think they've got to wait for the inspection to tell CQC stuff. So one of the things that we've highlighted today is that we can send the CQC anything you want. If you've got some really good news stories, or you've got some pieces of work or projects or programs that are really kind of like, taking us forward, then we can send them at any point and explain it. The other thing I was saying as well is that this is one of the very first inspection teams I have ever worked with who read what they receive. So the reason I say that is that yesterday it was meant to be a 2-hour interview with the CQC inspectors. It actually came out at about 30 minutes. And the reason for that is they had triangulated and read what they had received, and then they had mapped it into their Chloe document. And John Bruin's helpfully holding up the Book of Brilliance there. So they had taken all of that information that John is highlighting there, they had taken that, then they had mapped it into the Chloes. So when it came to talking to us and asking us questions, they said, we don't need to know that, we've already seen it. We don't need to see that because we've seen this fabulous piece of work you've done, or we've seen that you've already had an award for that, or you've done a really, really good piece of work around this pathway, or you've reduced some difficulties that patients had over here. So they were able to say, we've actually seen all the evidence, we've seen so much information. And I think as well that that is an unusual situation, that you've got an inspection team that are bothered, care, and have done their research and reading. So I think we're in a very, very good position with them. So that was the feedback we got from our session, is that we think we're going to start, we're not going to bombard them, but we're going to start sending them more good news stories and things that we feel that are good. So over to Linda, have you got anything? Wait, if we go any further, Katie, do you want to say something, Katie?
Yeah, I'm ever so sorry, and this might
right.
really. Where's best to send them?
Yes, to Sharon Rosenfeld.
Sharon, okay.
Yes.
Thank you.
She's the font of all knowledge.
Thanks.
Over to you, Linda.
Yeah, so our discussion was really, really helpful with colleagues, mainly around the mental health element, and what we're able to pick out, and helpful that Sharon Rosenfeld was in our group. There was the question around the number of files that had to be prepared previously, and Dave Owen saying, yeah, that really does scare the staff, but Sharon was able to talk through how the process has changed, and some of what you've already mentioned, Anne-Marie, around we can send them information in advance, and we can continue to update them. There was a huge focus around how we support our staff to understand the questions that are being asked and also to articulate the information, something around supporting staff to be confident. And very useful that one of our colleagues then said that the presentation from the CQC was very simple, so you could absolutely understand it. And is that an approach that we can also take so that staff can understand what the process involves and what they're expected to do? I think another valid point that was raised was around those questions that can be raised through data. So colleague mentioned that there's information we send, so giving an example of risks within a particular service, and actually how then we support staff to understand those risks so that they're in a better place to be able to articulate an answer, and if not, to be able to signpost for that answer. So we had quite a good discussion around that, and also mention around areas that colleagues would like to see in future events like this.
Brilliant. So I think from our perspective, we've done what the CQC are planning, what they are going to do. I've told you before at the beginning what services they're going to look at, which is CAMHS, Rampton, Arnold Large, adult mental health inpatients at this stage. When they've done that, when they've done all of that, so when they've done yesterday's and they've done those others, they will then give us a risk assessment. They will kind of like almost give a bit of a risk, where we sit on the risk scale. Once they've identified what our risk is, then what they will do is they will say, right, we've got to come in now because we're scared and it's really bad, or actually what we can see is you've done a really great job, we don't need to come in urgently or anything like that. So the risk score and the risk assessment will be quite an important thing, and it will be built up based on the conversations they've had and the information they've received. So I just wanted to let you know that that's how it will work out. And once they know that, and you could see from what Sarah was saying, she's desperate to help us get a different rating. She's really, she wants to work with us on this. She's had her hands tied behind her back, but she has really tried to on our behalves. So that's pretty much today's session. I just want to, the other thing, so Sharon has mentioned, offender health are also going to have transitional monitoring assessments done as well. Now, one of the things is if outside of the core inspection team that you've just met today, if anybody approaches you to say we need to set up meetings with you with regards to transitional monitoring arrangements, you must come to me and Sharon to tell us that this is happening so we can support you, because very, very occasionally it might occur that it comes outside of me and Sharon, and we wouldn't know that those meetings have been set up, so you just need to be all aware of that. So before I call it to a close, I'm going to just hand over to Dr. John Bruin, our Chief Exec, just to give us a bit of a summary from this afternoon.
Thanks, Anne-Maria. Hello again, everybody. What a great session. Thanks for organising it, and thanks for everybody's inputs. Just a couple of reflective bits, really. The first is that I don't think we'll ever be in a better position to really move up the charts in terms of what the official scores are, where we are currently unofficially, and where we can get to when the inspectors come back in. And that's backed up by all sorts of emerging evidence over the last, particularly 6 months, 9 months, that some of the softer signs of improvement are really starting to emerge, sort of a bit of a green shootsy sort of analogy. This will make Anne-Maria laugh. I'm not meant to tell any of you this, but I might have just one or two.
She's not going to do it again.
We've actually done quite well on the National Staff Survey with some of the high level, currently embargoed data analysis. So don't tell anybody, but there is some good news on the horizon, which is directly as a result of what you're doing in terms of your day-to-day work and your leadership. So that's a big thank you, and watch this space. I think the other thing to say about CQC is, I think organisationally, we've got ourselves into a bit of a standoff with them, and it was very much we were naughty child, they were the sort of senior parents, or parent-child relationship, which never ends well, and it didn't. You know, we've got a summary sheet with lots of red on it. And I think we've now got a much more adult conversation going on, and they're very clear and open and transparent with us, and the more we are with them, the better relationship you have. And it's probably a bit out of date now, but one of their seminal papers on that was called Driving Improvement is how mental health, learning disability trust improve. There's 9 key themes from national analysis. The first of which is guide you, you do better depending on how you receive your report. And if you can receive it well and take it on the chin and work with it, because most of what they pick up is right, you'll go far. And what the 9th thing is your ongoing relationship with them. The more that you can develop that close professional working relationship, the better you do. And I think we've done both of those things really, really well. So I'm optimistic. I think it's been a really good session. There's still lots to do, but again, thanks to Anne-Marie and the team, all the team, all the people, and all of you for doing this. And we do appreciate. There's 1 or 2 other things on our minds as well at the same time, but this is a fantastic piece of work. Thanks, Anne-Marie.
No, thank you very much, John. I think the other thing with the embargoed bit, which I have laughed at the comments down the side. So if Trump's tweeted it, we're all's lost really. But the other thing that I was also going to just mention is that we've done really well with flu, 76%, and we've also done really, really well with you know, the response rate to the staff survey. So it's not just about the staff survey, you know, as in what people have said, the comments that people have made, and the improvements and things like that. But to get a really good response rate is a really, really good thing for us, and that's one thing that the CQC do look at. They pay a lot of attention to what our staff survey says and the comments that people make. So it goes a long way to their impression of us. So, like I said, much further ado, I'm going to call it to a close. I want to say a huge thank you. And behind the scenes, we have people that are busy in a way, particularly Sharon. And she's an unsung hero. She absolutely is. But Sharon's done such a lot of work to get us into this position. And also for the fact that the CQC have named her quite a few occasions this week to say how well she's done and how much information she's sent them through. So I'd just like to say a big thank you to her, and also to Linda for facilitating the other session. So a massive thank you. So with everybody, hopefully you can have some downtime, and thank you so much, everybody. Take care.
Bye.
Bye. So my name's Anne-Marie Newham. I'm the Executive Director of Nursing and AHPs, and I'm just going to facilitate this session now. We were going to have a bit longer, but I thought it was important to give the time to the CQC and for people to ask any questions of the CQC, because it's a rare thing that we get to do, really. We don't normally get them where we can ask them whatever we want to ask them. So I think it was really nice of them to do that. But I suppose what I want to open up with, we've got quite a few people on the call, and this session really is opened up to the general health element of our organisation, because what we found is that people were asking for mental health and general health to be treated slightly differently, because they do have different needs. So that's why we've split it up. So this is really for our general health colleagues. So it was really around what did people feel about that presentation, and what did they feel about what they heard, and what do they think the key challenges for themselves will be. So any views at all? Donna will always talk for me. Donna, what do you think, Donna?
So I suppose I was hoping to learn a little bit more specifics around what they are actually looking for and how we can demonstrate that we deliver safe, effective, well-led, responsive services. Yeah.
Okay.
Yeah.
Specifically, for yourself, it's harder for general health, isn't it? Because for community, I think for general community, you've not been inspected since 2014. So I think it's a bit of a kind of like jump, from that period of time to now, and the world is so different for yourselves. So I'm not sure that we had enough specifics for that. Okay. Okay. Any other views on that? Anything else that people feel? Okay. If we're not getting enough kind of like detail, one of the things I think we could do is we could easily go back to them and say, what would you be looking for within community health? We do have, within the trust, we have inspectors that work in the trust that on the side do inspections. And we can easily ask people, you know, what do they think they look for in those areas. Rebecca?
I was just going to say that we've been doing a lot of work preparing for CQC since pre-COVID, because we thought we'd sort of been coming for a while, which is, I think, has been really useful. And I think for us as a team here, we've welcomed anybody to come and look at what we're doing. We've had the quality visits, which I found so helpful. Just that sort of critical friend, if you like, to come and say, well, actually, we found this. And also open up the conversations, which alleviates any of our anxiety and concerns, to sort of say, well, actually, we're doing amazing stuff. It really opens up. We all think, and she was right in what she said, we all think CQC is like, oh, dread, and it's not. We all do such fantastic work, and the quality visits for us really gave us that chance to talk about it and really try and shine, and get us into that habit of doing that, because I don't think we sometimes do it very easily. So that was really, they've been really useful.
I suppose I've got a couple of hands up, which is really helpful. So can I just, for all of you on the call, just to give a bit of context, what Rebecca and Donna are alluding to is something called Quality First. So we've got Sharon Rosenfeld, who's the CQC compliance person, but what we're doing is trying to build a team around her that does Quality First visits. And those Quality First visits are about delving into both environments and records, and what does it look like to be a patient in that area, whatever area it is, and actually kind of giving the area really good feedback, really constructive feedback, saying actually this is what we found and this is a really good thing, or this is something they would the CQC would be interested in, and then also giving them feedback as a report as well. So these Quality First kind of visits are really, really important to help staff to know what to expect when they have an inspection of any description. So firstly, Fiona?
Yeah, you've just said much of what I was going to say, actually.
Ah, sorry.
And Manji, we're just typing back to you, but I'll say it now. Of course, absolutely, Neds would really welcome sort of your support and everything to do sort of some of the Quality First visits. What I was going to add to that, Anne-Marie, of course, is although there's a core group of people who tend to do the visits, and we do want to increase that, and one of the things we're really trying to do is make it like a peer review. Yeah. So the more people we can actually get to participate in those reviews, the more learning and sharing and cross sort of fertilisation of good practice and things as well that we can do. I was also going to say that what we can do in your specific teams, if you want to, is to come along to your team, and if you really want to go through some of those specifics about how we'd interpret the key lines of inquiry for the kind of services you're delivering, and actually, you know, therefore what would be really good evidence for you to demonstrate and things, we can facilitate that, because I appreciate even in community services it's all really, really broad, isn't it? So absolutely coming along to specific teams about the kind of services delivering, we can arrange all of that. So just get in touch with us.
Yeah, and the other thing I was going to say is this, before I come on to Katie, the other thing I was going to say is that the CQC have got a really bad reputation for inspections being all about fridge temperatures. Now I laugh, right, because fridge temperatures, I don't know if all of you, because all of you smile, but fridge temperatures comes up on every single inspection I've ever seen. But actually, there's so much more. There's so much more to have a conversation about. Oh, yes. Carolyn, do you want to make a comment about that first?
Yeah, it's just picking up on a couple of things, really. I say I've been on both sides of the fence here, and I would really encourage clinical colleagues to just take the CQC on when the inspectors come on. Love them to death, really. Share with them absolutely everything you do. Do not assume that they know about your service, and the more specialist your service is, the less they will know about it. And the more you talk to them about all the great things that you do, the less time they've got to look for any little, minor issues. They will look at your resus trolley, they will look at your fridge temperatures and what have you, but the more you can tell them about the great things that you do, that your staff do, and the more engaged that they will be. So please don't be frightened. They genuinely, I think, in my experience, the teams I've been out with across the country really do want to help you evidence that you're doing the best that you can. And that comment about starting from good is absolutely true. They assume that you're providing good services, and it's only when they find something that's exceptional that they take you up a notch, or if you do something wrong, they'll take you down a notch. So they do assume that you're providing a good service. So the more you tell them about the great things that you're doing, and in the short time I've been with the Trust, I know there's loads of things that you're doing, but people sometimes just assume that people know that, or everybody's doing what we do, and actually it's not true. It isn't true. So please just share them and say, bombard them with information.
Thank you. Katie?
Hi, yeah, thanks. Just a couple of things in respect to our services, healthy family teams are out in the community, health visiting, school nursing, just for anybody that didn't know. We had, I've got a little bit of a problem around environment, because we did a whole heap of work last year around checking our environments, keeping them up to date with leaflets, breastfeeding friendly posters, all of that around environments. And because we're in health centres that we don't manage, they're not areas that we manage. The COVID situation has meant that everything's been stripped back, so there are no leaflets, so what I was thinking was, if the CQC are going to be coming out, is actually just showing them those documents those check-in documents that we use. We might not have any. But the quality of service that we had been checking before COVID, because a lot of places are looking very sparse, and that is obviously because there's the cleaning element, etc. And so I was just thinking I was going to ask them, but I'm sure it would be okay that we would show them those check-in forms that we haven't done them because there aren't any leaflets about or posters, but actually this was the standard that we were doing, that we were trying to reach. And also, just on another point in the respect to good news stories, I don't know whether this is helpful or not. I managed service manager for 3 areas, Broxtowe, Gedling and Mushcliffe, and I've put together quarterly newsletters for staff that are promoting both clients, patients and other members of staff, commenting on other members of staff and good work that's been happening over COVID. And I just wonder if those kinds of documents, if we are producing them, that we could perhaps show to the CQC when they do eventually come, to show that, because we're not getting as many SUS feedback forms in, etc. But maybe it's just another way of sort of promoting.
Katie, we don't have to wait. We don't have to wait till the inspector.
Just send them then, right?
Yes, we could just send them. And that was one of the things that they were saying. So for since I've been in post, right, we have sent them so much stuff. We don't wait for an inspection. We send it to them anyway and say, "Oh, guess what? Have you seen this? And look at how fabulous this is." And when Sarah Atkinson won the Nursing Times Award for the domestic violence card, we sent it straight to them and said that. We've sent them all the books of brilliance. We've sent them. So when they spoke to us yesterday, the interview was meant to be for 2 hours. It lasted 30 minutes. And the reason it only lasted 30 minutes is because they said, "We have got so much stuff." And this is one of the very first inspection teams I have ever worked with that actually bother to read everything we send. So what they then do is they read it and then they map it into their Chloe document. Whereas previous inspection teams I've worked with in the past, they receive it all, it goes into a big black hole, and then they come along and like it's all brand new. And it looks like, every day's a learning day. So, but for this team, they actually map everything and triangulate everything that we send, and they put it into the Chloe. So when we did the interview yesterday, they said, "Oh no, we've got a load of evidence for that bit. We've got a load of evidence for that," and it was absolutely stunningly fantastic. So it was a real pleasure to do, and it was very, very nice to hear them say, "Oh, I remember a presentation from this," or "Oh, we saw a really good leaflet on this," "Oh, we saw an excellent example of you doing that." But they were telling us things because we've sent them so much. So yeah, send.
Send. No,
Yeah.
no problem. Thank you.
Fiona?
I was going to say, one of the things obviously CQC also said to us yesterday is around getting teams to do presentations to them as well, wasn't it?
Yeah.
So if anybody really wants to showcase outside of an inspection sort of fantastic work they're doing, you know, through our engagement process, they're really happy to actually have presentations from teams as well.
We have something, for any of you on the call that don't know, we have something called a relationship meeting with them every quarter. So what happens is we meet with them every single quarter, and then say, for example, the first 20 minutes of that relationship meeting, they're happy to receive a presentation from a team. So we've done it in the past. So the last one we did is I suggested they came and had a presentation around end of life, because one of the things we picked up from the Sherwood inspection is that they didn't really understand the end of life alliance. So now we thought, right, if we explain to them what an alliance is and explain to them how the end of life pathway works across organisations, then they'll get it. So they actually had a separate presentation just on end of life alliance. It wasn't anything to do with anything, and they attended it. So there's options for us to do all sorts to broaden their understanding of us as an organisation. So the biggest thing for us as an organisation is to help them understand what we deliver.
Right.
Okay. So any other comments, really? Anything else that you think that the other thing is I'm quite keen to understand how we can improve these CQC preparations. So Donna came up with a good idea of, I'll go back to them and say, right, what are you actually looking for in general health and community services? Donna, you got your hand up?
I think for me, from a community health perspective, my focus is really about community nursing and how they kind of will focus on and how they'll get what they need from community nursing, because it's so disparate, isn't it? And it's so out there. And I just was interested, I noticed that the CQC are advertising for a professional advisor on community nursing. And I just wonder if that might, when that person is appointed, whether we might have an opportunity to liaise with that person and understand from their perspective specifically what they might be looking for.
I mean, there's no getting away from it, and my other exec colleagues will back me up on this. Sometimes with inspections, it depends who's on the team. So they'll have a core inspection team that are very good at just doing all inspections, and then they draft people in. So sometimes they might have somebody comes in who's really good at pharmacy, somebody who comes in at really good at clinics, somebody who comes in who's really good at end of life, somebody comes in who's really good at, you know what I mean? So they have, and so because of that, it can sway how the inspection goes, or the way the questioning goes as well, or what they're interested in. So yeah, that's just, it's worth thinking, but I think it's a really good point, Donna. Rebecca Smith? Hi, Rebecca. You got your mute on still?
Sorry about that. Yeah. So I'm deputy lead for Falls. We're working with Alice Kilby, and just having an oversight view of this, really from a more strategic point of view. I think there's a role here for kind of supporting in terms of feeding information back for problem solving and problem shooting with in relation to Falls. Since I've been in post, monitoring data with Falls, looking at spikes in certain areas, I think I've trying to look at embracing that rather than seeing as a problem, of how we can support that area to review why that's happening. And I think, you know, we're kind of doing kind of local reports and looking into action plans around what's happening in a local area to look at supporting the individuals there, to say, you know, maybe it wasn't avoidable, and rather than kind of trying to be afraid of the outcomes of what it might reveal, see it as a positive thing of how we can make positive changes and move forward by unpicking it a little bit further. So I think there's body of evidence there as a whole in terms of improving quality, that we're actually owning those incidents and situations and data, and looking at how we can move forward, and some of that might be valuable to feed into this discussion discussion.
Really helpful, yeah. It's a really good angle to take as well, because we don't really normally ever think about those kind of areas. So it is 10 past, well, it's 11 minutes past. Carolyn, did you want to just say something else?
So just very quickly, Anne-Marie, are we doing a trust response to the consultation document, or?
We haven't, and we haven't thought to do that.
I'll leave it with you.
Yeah,
I'll have a look. I'll have a look as well.
Sharon's
and
pretty good at
yeah.
picking up things like that, so I'll have a chat with Sharon about what we want to do. So I'm going to close this down. I want to say a huge thank you for your contributions, and just clock in now into the next session, which will just be the summing up, really, if I can find it.
Thank you.
Thank you.
Thanks.
Bye.
Bye.
Yeah, we've started to record the meeting. So my name is Linda Chibuzo. I'm the Deputy Director of Nursing, and I'll be facilitating this this discussion. So we want to look at 4 areas. I'm mindful of the time, and what we'll do is I'll collect the information that you give to me so that we're able to feed back. So what we really want to look at following the presentation from our CQC colleagues is your personal thoughts on the CQC process. So this is your sort of air and share. I'd like to also find out some of the challenges that you're having in terms of actually meeting the standards, the CQC standards. A little bit of discussion around what support you would like from senior leaders, from the organization, in order for us to be able to meet the fundamental standards. And then lastly, just to get bullet points on what sort of topics you'd like us to cover in future sessions. So this is one of many sessions to come. So we'd really like your input, if we can just work through those. So if I can ask colleagues, if you're not speaking, to have your microphone on mute, please. And then if anyone is wanting to raise an issue, speak, you can use the task on Teams to raise your hand. If you cannot use the task on Teams, just write into the chat and we'll try and pick those things through the chat. I've got Sharon with me, so she'll be assisting me in sort of picking up other questions that will come through the chat. But for now, it's over to you, colleagues, just on your thoughts around the CQC inspection process. So just for you to share your thoughts, feelings around this. I've got a raised hand, Jennifer Parks.
Hi, yeah, it's one thing that I know from previous CQC inspections that I've been involved with, sort of thing, and had. We always had to have several files set up with all different, and which was a lot of it was, so you'd probably have 4 files, and in near enough all 4 of them you would have near enough the same information duplicated. So in each one you would have a copy of a particular policy. It's been a while since obviously I've had a CQC where we've involved in those, and it's just curious as to whether that's still something that is expected of everybody when preparing for their inspections, if that makes sense.
Okay, so that's a very helpful question. I'm not sure, so I don't have the answer to that. But what I can certainly do is it's something that we will find out around having files ready.
Yeah.
I can answer that a little bit. Thanks for the question. What we don't want to do is create an industry around this. You've got so much to do already, but we do have lots of initiatives coming out about how to capture the good work that people do in terms of the Books of Brilliance and other arrangements that will be putting forward. I think there's going to be a lot of information coming out about understanding the standards and how we know them and how we can evidence them more easily than having books, having files that we have to then keep up to date all the time. But it is something that we've got to get better at, to understand what the standards are, how we're meeting them, where we're falling short, and actually we will always fall short on some standards. Things won't always go swimmingly, but it's what how you recognise that and then what you do about it that counts. So we have also a tool that we're hoping might help frontline staff and departments within the organisation to sort of keep track of their own compliance with the standards, but it's something that isn't a massively bureaucratic thing.
No problem.
And also, we need to think about how we get administrators more involved in the inspections. The focus of a lot of the inspectors' time is obviously on the delivery of services, on patients, on those staff. But you know, the whole team have a very important part to play in the delivery of services, as do corporate services. We're all linked in some way to ensuring that services are delivered safely and appropriately. So we need to look at that as well. Thanks, Jen.
That's brilliant. Thank you.
Thank you for that detailed response, Sharon. So for colleagues who have just joined, we've got several colleagues who have just joined. We're discussing the first question that's here for you to just share your thoughts on the CQC inspection process. So Jennifer just asked around having files, information prepared, ready and waiting when CQC visit, and Sharon was just answering that. So if colleagues can share their thoughts or even questions around CQC process. What we can't answer, we'll go away and find out. What we can, we'll have colleagues answer, and useful that Sharon is here in this breakout room with us. Any other comments, areas that colleagues want to share?
I think somebody mentioned something about restricted practice.
Yeah, so I've already sort of responded to that around, this was to say that's for a future session. So I've made a note of that, and it will answer sort of our question 4. It will be part of what we'd like to see in future. So Andy, you've got your hand up.
You're on mute, Andy.
Yeah, you're on mute.
Oh, blimey, I did some amazing stuff. I was saying that if we're talking about stuff for the future, we need another session on IPC. We had one before in this forum, and it was just before COVID hit. But I think every ongoing assessment from CQC is going to have IPC front and centre, so that would be quite a useful thing to do. I think staffing is a feature of every CQC review, and even with the improvements in adult mental health recently, I've noticed that still issues around medicines management come up, so they could be decent future conversation pieces.
Okay, thank you for that, Andy. Anne Wright, you've got your hand up.
And just to add to that, could we put in the physical health care as well, please?
Okay, thank you for that.
Any specific elements of that? Sorry, any specific elements of that?
I think if we use news as a structure for that, that would be helpful.
Thank you.
And diabetes, etc.
Okay, so we've got a few sort of thoughts around the inspection process. I won't dwell on it too long. If people do think of other things they want to share, they can actually put those into the chat. So moving on to the next question that we have, because I'm mindful of time, we go back in 10 minutes. What are the key challenges in terms of meeting the CQC standards that colleagues think they encounter or have encountered?
I think it's something about, and they've touched on this, but how staff are able to articulate and understand what's being asked of them. And there's something about language that's used. So how we support staff in feeling confident, and I suppose just having that open conversation so that it's a two-way thing rather than, oh, I'm being asked a big question by somebody scary. Encouraging them to dig a bit and find out what they're really asking.
Thank you for that. That's really helpful. Sharon,
I think one of my concerns is staff have been so focused on COVID that we've lost something along the way. And I think it's just getting people motivated to start thinking about what they're doing, why they're doing it, and feeling positive about it. I'm not saying that we've lost all that, but what I'm picking up with some of the staff is they're tired. So how do we start motivating staff again to really get on board with this?
Okay, that's really helpful. Alison?
Sorry, I'll start again. I was on mute. I think it's on the back of what Anne was saying. It's equipping staff to feel confident when the CQC asks questions. I think there's a sort of anxiety before we start, and just to really reinforce the message that everyone's on our side, really, and to try and manage the communication about CQC, that it's a positive structure and a positive process, so staff can relax a little bit and celebrate the positive work that we do, and be confident if they don't know something, that they know how to escalate or where to go for that information. And I think it's how we manage it as team leaders and service leads, that it's okay. It's an okay process, really.
Yeah, that's really helpful. I'm hearing this around us supporting staff and colleagues to sort of rebuild that confidence, because I remember, sort of CQC inspections when I was a junior practitioner, and also later on as a team manager, ward manager. It is quite difficult, and a lot of the times, you don't plan what happens on every day. So that's a very valid point that you've raised. I can see Dave, you've got your hand up, Dave Owen.
Yeah, just to follow on really from that last point, I mean, my previous experience of inspections and the like has been very much around, files as big as you, whatever, sort of telling you what everything that they're going to sort of inspect right down to the last sort of, sort of button basically, and that scared people. That has literally put the fear into our staff teams, and I think we've definitely got to have a different sort of style of how we prepare for these inspections, and very much like what has been said in the first session and by a number of people already. It's got to be an inclusive. People have got to be made to feel relaxed. They've got to be to be able to sort of talk about what they do and to share, their work and the difference that they're all making in a positive way, and the Book of Brilliance is a really good start, and we need to develop on those sort of lines, I think.
Thank you for that. That's really useful, and you're right. There is something around how we will frame our tone so that we can change a negative to a positive. So we need to be identifying and role modeling that CQC inspection is an opportunity. It's an opportunity for us to showcase our work, the behind the scenes work. So what's already been mentioned by Sharon, that this includes our non-clinical staff, our administrative staff, domestic staff. So we just need to frame how we are preparing and how we are communicating those messages. So that's really important. Thank you for that. Paul, you've got your hand up.
Thank you, and I just wanted to add on to what the last couple of comments have said. I think it's really important that we remember that this is a team effort for us, and I think when I know myself that when you're on the receiving end of being interviewed or questioned, you can almost forget that it's not just all about you, and it's really important. If we come out of an interview and think, oh, I forgot to say such and such, or I come out, I've had the experience where I've come out and thought, I'm not sure I gave a good enough answer on something. Rather than just berating ourselves, one of the things that's really important is that we're able to enable you to give feedback really, really quickly to the rest of the team who are supporting the CQC visit, so that other people can then get a bit of a heads up. So I've certainly known that I can think of an example where there was something really important, and I know the answer I gave wasn't clear enough. So being able to pass that on to somebody else who was next on the list for an interview actually meant that that person could shoehorn a good answer and just get the information in there accurately. You know, this, as was said in the session earlier, it's not about trying to trip any of us up. And I think that we need to look after ourselves in this. And, you know, sometimes you can have that situation where if they'd come in the day before, you know, you would have been fine. But if they're seeing you on this day and you've had a really tough morning, actually you might not be as fully on your game as you were yesterday. That's okay. You know, it's for us collectively to be able to work to give them the best possible view of us all as a big team.
Thank you for that, Paul. Any other comments on sort of the key challenges? So some of the things that have been mentioned by colleagues I've already noted as the sort of support that we need. So part of our next question is answered. So if we just move on to that next question, the next question around what support do you need, or what support do we think we need in order to help us to meet the fundamental standards of care? So some of the things that I've made note of already is around being able to shout out and showcase our good work, like the Book of Brilliance. It's also around what Paul has just mentioned, that it's a team effort, and remembering that actually you can pass the baton to your colleague who's due to have a meeting shortly, so they could actually clarify some of the information that you will have already presented and mentioned. So are there any other areas that colleagues want to sort of suggest on the support that we can look into putting in place? Richard, you've got your hand up.
Do we, as services, do we understand our service risks? So what I mean by that is, do we understand the risks and then the questions the CQC may be looking into around that service? So they may be operational, they may be performance, and if we know, I suppose, do we know them anecdotally, or have we got evidence to say that, for example, we're an outlier on a certain intervention, so that's what the CQC will be looking at? Does that make sense?
Yeah, that's a really helpful question.
So I suppose the data-driven questions that we could generate internally to predict where the CQC may look next.
That's really helpful, and I certainly know that from some inspections that have been held where there is a risk, especially when we talk of something like a ligature risk, and actually those who are working in the unit were not aware that it's very, it's very high on the risk register divisional organizationally. So some of that information is quite key around those data-driven questions that they may then prompt and prod a little bit more. And again, coming to the area of staff being confident in actually saying, I'm not too sure, so I don't want to give you a wrong answer, but actually I think Andy could give you a better answer to that. So they may then push and just say, what do you think? So what I think is quite safe, but actually it might not be as accurate as I'd want it to be. So there's something about us sort of providing that support and having those conversations around those data-driven questions. I'm mindful of the time, so I'll just ask you, Anne, to give your last comment, and then from there we'll need to go back into the main breakout room.
Thank you. It was related to that comment actually, and it's about how we keep information simplified for staff. Because we get reports and they can be quite complicated. We need to keep them simple so that staff understand them and feed them through our governance processes so they go right down to the board, from the board to the ward in reality, and that people can talk about them in a very simplistic way. And I think the way that the CQC did their presentation was a really good example of some plain speaking language that we could understand. So if we can follow that, that would be great.
Okay, thank you for that. So just to share with colleagues on the last question around what you'd like to see in future. So I've put down a future session on IPC, restrictive practices and being able to justify them, medicines management, physical health care, around a deteriorating patient, and the use of news too. So if we can just go back into our agenda and click on the first link, please, so that we can go into the same room as other colleagues. Sorry to have to rush everyone, but thank you very much.
Thank you.